Hi, friends. I wanted to give you a little more of a personal update and some lessons that I've learned from taking care of my father, who is in the hospital right now. And I'm a doctor, so I've been trying to not be too overly involved. And they say we make the worst patients, but I want to provide you with a couple of tips that I hope may help you with your family members who are hospitalized. And this is some of the things I've learned through personal experience as well as professional understanding. So, first of all, my father is 84 years old, so he's quite frail and has multiple medical problems. But the first thing I've noticed is that you as a family member have to be present and you have to be an advocate. You have to be visible to the staff because let's be honest, a lot of times people in the hospital are really busy. So they're not going to do their best when family members are not around, which is human nature. People cutting corners, people doing just the minimum. And you have to be an advocate for your family member. And staff knows this. So when they see families are involved, they're much more likely to do a good job and go above and beyond. And when I was working in the hospital, I think this is an unconscious thing that we all respond to as doctors. So you want to do frequent check-ins with the staff because they're coming on every 12 hours or whatever, and you need to be helping them understand the continuity and care for your loved one. The details will get lost. So you need to be tracking all the details yourself. You can notice the subtle changes that other people are going to miss, and you can make the continuity happen between all the teams, the cardiologists, the gastroenterologists, the primary team, the nurses. If you can know the names of the people on the team and you can understand what each of them is responsible for, you can make sure that your loved one is getting the care they need. I can tell you there's been many times when I've been able to connect people and correct mistakes that some clinicians have been making, and that really made a difference. For example, my father went to a rehab facility and they forgot to give him the correct insulin doses. And because of that, his blood sugar went too low. So I was able to identify that problem for them and make sure they were able to fix it. And when he went back to the hospital, we got that taken care of. When people are really sick, a couple mistakes can really basically end their life. So you have to be polite, but also persistent when you notice something that's not making sense. And even if you're not a doctor, you have basic understanding of your loved one that the doctors don't have because they're always changing shift. So it's important for you to ask for clarity. And it's the responsibility of the doctors and the nurses to explain things to you in a way that you can understand. So don't worry about being annoying. A lot of people worry about that. It's better to be a little bit annoying and help your loved one out. So number two, I would say, is you want to track all the details of the hospitalization relentlessly. You want to be almost OCD about it. Keep a journal with you, write down their medications, the changes in medicines, the lab results. And many times hospitals will have a portal where you can actually sign on and you can see all of the updates as they come in. So you can track this online. You might even know the lab results and you might even see the notes and read the notes before the clinicians on the team get access to that stuff. That's a really amazing feature of technology that'll help you. And also keep a journal that includes symptom changes. So if somebody has shortness of breath or chest pain, you want to actually track that over time because it's easy to have the days blend together. And sometimes people can't remember, was that like 2 days ago, 5 days ago? When did the chest pain start? When did the oxygen saturation go down to under 90%? Because especially when people have long hospitalizations, then they're going to have trouble remembering things. And also you're going to have trouble remembering things. So write it down. And then you can be the one who clarifies the timeline. So for example, you can say, look, this person, my husband, my wife, my child, my parents, their shortness of breath actually started 5 days ago, and this medicine was started 3 days ago. So I don't think we know yet. Or you can say, we can't infer that this caused this because it was before that. And the team is going to really be taking care of 20 people, 30 people, who knows? And why should they really prioritize remembering all the details about your loved one? That's really on them or you or the family. So number three, I would say you want to really be careful about the weekends. Everyone knows that the weekend is covered by the B team in some sense. So there's a lot of doctors and nurses who do the weekend shift or they do overnight shifts, and they tend not to be as on the ball because either they're half asleep overnight or on the weekend, they're people picking up extra pay. So it's not really like their main gig and they're not really as invested in the work. Now, there's obviously very caring people everywhere, but I'm just talking about on average. If you meet somebody who's on the A team on a Tuesday morning, they're going to be different than the person covering Saturday morning, Saturday night. So keep that in mind. And you want to be the one to bring that continuity if there's differences in staffing and specialty on the weekends. And sometimes, here's another tip. If something is developing and you're worried about it, like, for example, somebody's developing some mild chest pain and they're not sure whether to do the test, and it's a Friday afternoon, that's when you want to push for the test before the weekend starts. Because if we let this hang on when the weekend comes, if something does get tested and it's positive and somebody has to act on it fast, the team that's going to be working is not going to be maybe the A team. So get it done on Friday. The other thing you can do as a loved one is really advocate for avoiding deconditioning. When somebody's in the hospital for more than a couple of days, they're going to just be sitting on the bed for a long time. And that's going to be one of the biggest risk factors. You might be focused more on their kidney function or their breathing, but really the deconditioning can really inhibit them for weeks and months and even prevent them from leaving the hospital and cause other complications like blood clots and worsening chest pain and so on. So you want to be the advocate for physical therapy and occupational therapy, PT and OT. You want to be the one to really be there with the person when they're going to give up and they don't want to do more physical therapy because they're tired and they want to go back and just lie in bed. That's a huge thing that if an outside person is encouraging them, it's not going to work as much as if a loved one is there. The other thing you can do is watch out for delirium, especially for elders and especially elderly men. Delirium is something that's going to develop, especially when nighttime comes. So you want to really focus on reorienting the person to where they are, what they're doing, why they're there in the hospital, what the goal is, what the plan is, who you are, who they are, and any progress or lack of progress so that they have a sense of a continuity of time. And your loving presence will give them that orientation and that motivation over time, hopefully. But delirium is something to watch out for, and that's something that a family member can make a big difference in, because when delirium starts, that's often a bad predictor of increased mortality risk. And we want to avoid delirium, and then when delirium starts, we want to get rid of it as soon as possible through improving sleep, improving circadian rhythms, and cueing people to the social environment and what matters to them. The risk of dying goes up with delirium, so you want to really take care of that. And also, the reason you don't want delirium is because it can mimic a lot of other stuff. Like when somebody has an infection, they're going to have some kind of changes in their mental status or their cognition, but that can be confused with delirium as well. And then you can't really tell what's going on. So the less delirium you have, the better for a person. And the same is true for medication side effects and electrolyte abnormalities. These things can all affect the mental state. So you can be their delirium coach in some ways. You can be the person who tries to get them out of it and prevent it. Next, I would say number 5, communicate with your team strategically. You want to develop a ritual with the main team so that they have a huddle with you. So they don't just think of you as somebody hanging out, but they want to have some responsibility to check in with you. So once a day, we need to have an update on how my loved one is doing. And you can be the one who says, what's the plan? Where are we going here? You don't want to get too involved, because sometimes when people are too involved, they become annoying, too annoying. And there's a saying that doctors make the worst patients because we tend to ask too many questions and we tend to be too involved. But a loving family member who huddles once a day is going to be just fine. What often happens is the care plan for a person will drift. It'll just hang out. We're just hanging out, getting some fluid off. We're just hanging out. We're monitoring the kidney function. We're monitoring the breathing. But there's no active plan to get them better. There's no aggressive, goal-directed plan sometimes, because people just hang out for weeks in the hospital or days. So you can be the person to direct the plan and remind people that there's somebody here that's bringing accountability to the plans and the goals of care. So make sure that you know what the goals of your loved one's care are. What is their baseline function? Where do they want to get back to? What are their goals and values and priorities? You're going to be a crucial input. And without that information, the team just doesn't really know what to do. And they may default to some of these other more convenient things for them or the hospital. Number 6, I would say you need to be the external brain. You need to be the memory system for this hospital system, which has amnesia, because the hospital system itself changes all the time. Like I mentioned, teams are changing daily, and you're the only one with constant contact with your loved ones. So if there's a change in the plan, you need to be the one that provides continuity. You need to be the one who is reminding them, his baseline kidney function is this. So you're calling this abnormal, but that's actually better than his baseline. So you're making a decision. Now I'm talking hypothetically to some hospital team. I might say, you're making this decision assuming that his kidney function is down, but actually it's his baseline, if you look for the last 1 year, is much worse than where we are today. So don't make that decision. So you can bring added context And that's going to be really important because nobody loves that person more than you. Nobody in the hospital cares more for that person more than you. Number 7, you can be the person to mind the transitions. You can make sure that transitions do not result in disasters. So when they go from outside into the hospital, when they're admitted, you can be the one to have their medication list and make sure that the medication list is actually reconciled correctly. That's where huge errors happen and that's where delays happen. You can also be the person to help transfers between units. If somebody goes from the emergency room to the main floor and then goes from the main floor to the ICU, you can be the person to remind people of what just happened in the other place because everything's so modular and disconnected. There needs to be somebody who can remind each team of all the settings on the oxygen or the orders or the medications or the allergies. Just to give you an example, my father had an allergy to an antibiotic and I was able to remind them, you don't want to give that one again because that resulted in an anaphylactic reaction last time. No, these kind of things should be in the chart, but of course, people don't look sometimes or they're busy. That's how medical errors happen. There's tons of medical errors. People, unfortunately, die from medical errors so often, and you can be the one to prevent that from happening. And the other transition that matters is from the hospital to home or hospital to rehab. There needs to be a really seamless transition to follow-up appointments, medication changes, and then other warning signs to bring the person back to the hospital or not. That's really crucial. And the biggest risk for someone is right after they leave the hospital. That's true medically, psychiatrically, and otherwise, because that's when they're most vulnerable and they need the most support. So that seamless transition can be a really huge thing to help with. Number 8, you want to prevent a readmission to the hospital before it actually happens. So you want to instruct your loved one as well as other caregivers about the discharge instructions. You want to go over discharge instructions line by line. So you really understand, if this happens, I do this. If that happens, I do that. And normally before you leave, the clinicians will talk to you about discharge instructions and you want to specifically say things like, what kind of things should I watch out for to come back to the emergency room? Specifically, what oxygen level, what heart rate, what blood pressure, how much of a decline in functioning. And then when someone's back home or in rehab or at an assisted living facility, you want to be able to ensure that everything's set up there. They have the support, they have the equipment, they have the medications, the pharmacy's been called, the meds have been ordered. Those kind of things are huge because when people land at home, they often just bounce right back to the hospital. And that's not a good outcome. Readmission is definitely not a good thing. Number 9, I would say you want to advocate for nutrition and hydration. One of the biggest things that's ignored in the hospital setting is adequate nutrition and hydration. And these things are huge because if people stop eating in the hospital because they're going through operations or they're having procedures or they're just tired and they don't have energy, you can be the one to coach them to eat more protein so they don't lose muscle mass lying on their bed. Or you can be the one to encourage them to take in enough fluids to stay hydrated because a lot of medical problems start and also get worse with low nutrition and hydration. For example, anemia is a big problem, and anemia of chronic disease is a big problem. And without adequate protein intake, your bone marrow is not going to be able to create new red blood cells. And that's something doctors are not really attuned to because they're just doing their thing at the complex physiological level, and they're not thinking about these more basic things very often. So they just throw some food at a person and assume if they don't eat, that's fine. That's their level of hunger. We're going to just report that as it is. But malnutrition can be a big problem and it can definitely slow recovery and can make recovery even not as likely. So you can advocate for a nutritionist consultation and you can advocate to your loved one, especially if they're older, to improve their hydration, to prevent dehydration. And you can track input and output. So for example, in congestive heart failure, you need to have very careful input and output records. How many milliliters of fluid did the person take in and how much urine came out? That tells you if your diuretics are working. That tells you if the treatment's working. The nurses come in and out, they maybe measure it. They're not going to be as on top of it as you. So those crucial decisions that are being made, do we escalate care or do we change the medicine? Those are often made on data points that are not accurately characterized. So you can really help with that. Number 10, finally, I would say is you can be the one who balances trust with verification. You want to trust the main team. They're there to do their job and you can assume that they do care for your loved one. However, you got to verify things and you can't assume that they're perfect angels or that they're perfectly competent and that their attention is always on and they're not tired all the time. So you want to verify lab results, orders, medication changes. If something feels off, hey, look, my mother, my father, my son, my husband, my wife, whatever, they just look worse. They have an unexplained fever. And it's 101 and the doctors are saying, that's not really a fever. 102, 103. We start worrying there and say, look, I know it's not a big deal. Could you just try this out for me? Could you just call that consultation and let's just see. When you speak up, people are going to respond and you can notice a rapid decline much better than somebody who's seeing them for the first time every 12 hours. So these are some of the lessons I've learned from taking care of my father, and I hope they're going to help you and your loved ones. If this has been helpful, I really hope someone can benefit from my experience. Take care.